It's a pleasure indeed.
It's always exciting to see you, knowing all the good you're doing for Mother Ghana and for our sisters. So today the discussion is on PCOS.
Yes, indeed.
Polycystic Ovarian Syndrome. Big word. What is it?
It's a condition that affects, well, for now, we say it affects women. I have an argument somewhere inside there that I don't think it affects only women.
But do men produce ovaries?
No. But if I explain the nature of the disease, you'd realize the fact that women manifest it in a particular way. And there's no reason why we cannot say that men also manifest it in a different kind of way. I know I'm starting controversially, but
controversy is good. Controversy is good. Okay.
Well,
so
when I explain the building blocks of the disease condition, you ask yourself, so why can't men have the same problem? The only difference is that men will not manifest it the way women do.
Okay.
We'll get there.
So what is PCOS?
Okay, it's a condition that we have described, and in women, the initial finding was that we did a scan for a woman, and you notice that she's got multiple follicles on her ovary. Now, every month, usually we expect you to have 1 or 2 follicles, maybe 3 or 4 on your ovary. But on these women, we see a chain of follicles forming a circle around the edges of the ovary, and the center of the ovary usually doesn't have any follicles. So it forms a ring around it. And there are multiple follicles, usually more than 14. So when you look at it, you shouldn't be like that. And that is where the polycystic description came.
Multi. Plenty.
But then we also discovered that there were other things that went with it. That's why it became a syndrome.
Okay.
So it is, yes, multiple or excessive number of follicles on your ovary, which shouldn't be. And then we discovered that those people tend to have an abnormality with their menses.
Okay.
Which shouldn't be. And then those people tend to have manifestations of excess male hormone on their body, which shouldn't be. So when you combine the abnormal menses, abnormal looking ovaries with abnormal levels of male hormones in their body, or manifestations of male hormones in their body, then we bring all those together and we describe it as a syndrome.
Okay. Oh, wow.
You understand? So that is how the name came about.
Polycystic Ovarian Syndrome. Okay. Common symptoms. Well, how does it show? That's where we're going to get into the Lancet. People will come after you. We're going to publish in the Lancet and they will come after you.
Okay. So for women, what do we see? The woman comes, sometimes says her menses is not coming. Her menses, when it comes, is too long. But it doesn't stop. Small amounts for a very long time. She's got difficulty in getting pregnant. She doesn't notice the fact that the ovulation symptoms that we all describe as before ovulation, she doesn't have it. So she comes and says, I don't think I'm ovulating. Some people can go about. I met a woman who has her menses once every 3 months.
Okay.
So she has like 4 menses in a year, but she's got 3 children. So even though she had that problem, she was still able to have children. My conclusion is that she has a lot of sex. And so her few chances that she has, she managed to have those children. So to her, she's normal.
Okay.
Oh yeah, I met her in the Eastern region. To her, she's normal.
Okay.
But in actual fact, there is a problem. I met somebody this week who said when her menses comes, it stays for a long time. And so she thought it was due to the fact that she has some kind of infection. And was attributing
normally it would be for how long?
We'd expect that for most people within 5 to 7 days, most people would finish.
And this one will go for like
and
how
this
many?
one will go for like 3 weeks.
Oh wow!
Yeah, she was bleeding continuously for 3 weeks. Not heavy amount, like small amount. So when she described it, she was attributing something that happened a year ago. I'm like, nah, it doesn't work that way. It's not likely. Did a scan for her. Oh, okay, we've seen the problem. Your ovaries are polycystic. That is why it happened. So for some people, they see it more as a menstrual manifestation, abnormalities in their menses.
Okay.
Too long, too short, doesn't come at all, kind of problem.
Oh, okay.
Then there are those that also manifest from the excessive acne, pimples, especially face, chest, back. Some are also very hairy. So they've got hair in, women who have got hair in abnormal places. So you look at it and you're like, nah, this is not right. Now, the interesting thing is that those are excessive manifestations of
the
male hormone.
Okay, yes, you
But
said.
what is interesting is that oftentimes when you test them, their male hormone levels are normal. So we cannot exactly say automatically that it is a direct manifestation to a high level of hormones, because for our people, the male hormone levels tend to be normal.
Oh, wow.
So there's still more investigations we have to do on that aspect to see how. I think maybe you just make their things a lot more sensitive.
Okay.
Yes. And then so somebody may just notice that, like I said, pimples, excess hair all over their body, and they may not, and then menstrual irregularities as well. Then there are those who would also notice. Then when we do the scan, we come with the complaints and we examine you, do the scan, we see the ovaries look polycystic. And then we say, you've got the condition. There are others too who just have a problem with what they notice is that they've got challenges with their weight.
Oh, okay.
And they have difficulty in losing weight. They can do everything. Everybody loses weight, but they will eat the same food with everybody else, but they alone are not able to, are gaining weight. Some will say, I don't even eat. I eat once a day, I'm still gaining weight. But that is because of a problem that is behind all this. And that causes them to have, not only do they have do they gain weight easily, they have great difficulty in losing weight. So for the client standing on the outside, this is what they notice. Then if you go to the hospital, the doctor runs the tests. He does a scan, and there are hormone tests that you can do. And those hormone tests will actually tell us that, in actual fact, you have this condition.
Can I ask? Jump.
Ask. Feel free.
Is it deadly?
Is it deadly?
Yeah. Is it fatal?
Directly, no.
Okay.
But indirectly, it can lead to things that will kill you.
Please explain.
So, if because of this condition you're not having your menses, the nature of the condition ensures that you have excess what we call estrogens. Now, in a cycle, you've got estrogen during the first half and progesterone during the second half. Because they don't ovulate, they don't produce the progesterone for the second half. So the estrogen continues. Then if they don't have a menses, that lining that has been built by the estrogen does not shed. So every month, the estrogen builds your lining. It's like preparing your bed.
Exactly.
For a baby.
Because a baby's come, yes.
And then when you ovulate, you produce progesterone to support the pregnancy for it to stay. Now, if you ovulate and you don't get pregnant, then the progesterone levels will drop after a week of progesterone. And then the bedding that you have prepared, the endometrium, is shed as the menses.
As the menses, yes.
What happens when you don't have that menses is that, first of all, you don't have the progesterone. That stabilizes the lining and tells the estrogen, hey, stop what you are doing, don't grow anymore. And so at the end of the cycle, you don't shed because you don't have the progesterone withdrawal.
So the next monsoon builds on it?
So they build on it.
Oh, wow.
And it keeps building first month, second month, third month. By the time it reaches fourth or fifth month, then it becomes a story building that has an unstable foundation. But it wasn't meant to be that tall.
Oh, wow.
And then it starts breaking. Now, it doesn't break like how like a controlled explosion. You put your bombs at the right place, poof, then the tower comes down. It doesn't collapse that way. No. It collapses in pieces. Today, room 1 will break. Tomorrow, part of room 2 will break. The next day, room 52, part of it will break. And that's how it breaks. And because of that, you keep bleeding. When you start bleeding after 4 months, you can bleed for a whole month. Because it's the building, the lining that has been built does not come off as one like the menses comes. It breaks off in pieces. And as it's breaking off, it's trying to rebuild where it's breaking off. Then another portion will break. Then down to start bleeding. Then it's trying to rebuild up. It just keeps going on and on and on and on.
And that will, throw you off.
Totally. So she comes and it's like, I don't know what is happening to me. I can't tell you my last period. I can't tell you my menses. I've been bleeding for the past 1 month.
Amazing. Yeah, this is worrying.
Yes, it is.
Now it is worrying.
Now that lining,
if
it is building like that, uncontrolled, the continuous exposure to estrogen can cause the cells in the lining to decide that since you are overfeeding me with this particular thing, I'll start misbehaving.
Oh, whoa.
So they are at increased risk of endometrial cancer.
Okay. Now I understand why it is deadly.
Yes.
It may be not directly,
but over time, over time, it
can
now,
lead to that.
if you have this condition and you don't address it over the next couple of years, invariably, it gets worse. The foundation of this is a foundation of a problem we call insulin resistance. That eventually results in you becoming type 2 diabetic.
Oh, wow.
So you start with PCOS, you end up being diabetic.
Because it's something just not right.
Yes, something.
And it leads to something else and leads to something else and leads to something. So talking of, you just said if you don't treat it, how is it diagnosed? How would you know?
So you have your problem, you have your complaints that you have. And because of the complaint, you go and see the doctor and say, hey, this is what is bothering me. So the doctor then decides to examine you and then does a scan. There are some blood tests. There are blood tests that will actually tell us that this is indeed a condition. And once you have it, we tell you that this is what your problem is. Okay. And then we then have to decide what to do next, which is based on what your requests are.
So what then would you say? Because some people are already joined us. Is it TikTok Live? You can join us right away. The handle is @Z Multimedia on TikTok and YouTube. On Instagram, Facebook, and on X, it is ZFMGH. It's fast approaching 9:15. Dr. Paddy is in the house. We're talking PCOS and all the things that comes with it. So you spoke of scanning. So the person comes, complains, and then you know that this could be it. What are you scanning?
Okay, so when a patient comes and complains that this is what the problem is, sometimes when they start the complaint, you cannot know what the problem is. If you know it, you know it. Yeah. So they start the story. As a joke I play on my patients sometimes when they come in, they tell you the complaint and you say, "Oh, I know your problem." Then they're like, "Oh, what's so?" It's like how the herbalists do, and you go say, "This is this. We can do some."
All you need is some sound.
Oh, some sound.
Yeah. And some powder in the air. Yeah.
But actually, when the patient enters, you look body type, nature of their face. The moment they tell you that this is what the problem is, like if you have 1 and 2 already, you just need to add a 3 to it, and you cannot know what the problem is.
And then to verify,
you do the test. But the easiest thing to do is a scan. Now, I do my own ultrasound, so if you come,
you don't send them anywhere.
No, I don't send them. But other people may have to request for you to go and do it. And then when you do this ultrasound, you are looking at the ovaries in particular, and then the lining of the uterus. The ovaries will tell you with that arrangement if they've got the follicles that are arranged in that particular manner, and that kind of confirms it for you that this is what the problem is. And you also want to look at the lining of the uterus to see how thick it is. But if it's very thick, then you are thinking of, I need to intervene because I can't allow this to continue because you'll be at risk of endometrial cancer. So, but an ultrasound, you're able to, to do it and pick it up and find out.
So what are the causes? What are the risk factors? Is it genetic? Is it something
so this is where things get a bit more complicated.
Oh, wow.
Officially, they say the cause is unknown. But one of the things that underruns all of them is that they have a problem with their insulin metabolism. So after much research, I have a theory.
Which we will publish in the Lancet. So that one of these days they'll come for you.
Yes, they'll come for me. But, and that theory, we've been running with it for a little while, and we found evidence that consistently supports it. And it has affected the way we're managing them going forward. And the result is that we've been getting better outcomes. There are multiple challenges that comes with this condition. But the cause is genetic.
Oh, wow.
The cause is genetic. And we believe that it's due to a particular deficiency that the client has. Doesn't produce a particular kind of enzyme. That enzyme doesn't allow it to produce a particular kind of key. That key opens a particular door in glucose metabolism. That's where the diabetes end story comes in.
Yeah.
It opens a particular door in glucose metabolism. And if that door opens, you function normally. But because you don't have that key that opens that particular door, you are not able to produce the right outcome. The end result is that sugar accumulates in your blood. And because sugar accumulates in your blood, your body is compelled to push that sugar out. That process of, I'm going to push the sugar out, causes your insulin levels to rise. Your insulin levels rise to try and push the sugar out to keep your sugar normal. Every time we check your sugar, it will be normal for 20 years or 30 years. After which, it will become abnormal because you have overused your engine that produces the insulin. And so that engine fails. Because the engine fails from the excess overheating, it's not able to produce anymore. And as a result of that, your sugar then starts rising. And that's why you become diabetic.
So PCOS and diabetes go hand in hand?
Yeah. So in other words, if you're able to manage your PCOS well, you will not become diabetic.
Okay.
And that also means, now after I've explained this mechanism to you, why don't men have the same problem? We also have the same enzyme. We also need that key. The only manifestation between we, the men and the women,
because we don't have ovaries for it to be polycystic.
And if you have excess hair, we think you are cool.
Yeah, if we get beard, I mean bearded gang.
Yeah.
Bearded gang and all.
So you don't see.
Oh, okay.
So now you see.
That's a worrying thought.
Yes. So as you are walking about here, we are having our own version of
Yeah, I mean, it's kind of interesting when you think about it, but you're absolutely right. It could be that ours is being manifested in another way. But because the things that would make it easy for you to detect in the woman, the hair and the rest, it comes naturally to men. So we're swerving and it's looking, and then eventually to still lead to the same end goal, which is the diabetes.
Yeah.
Okay. Wow. That's. It said that about 10% of the global women suffer this thing.
Yeah, thereabouts.
Has there something that has been found to show that it is prevalent in some races or some groups of people? Because
Massa, we all have it.
Everybody, white, black, Indian.
Yeah, because they said if it's a key that you don't have, it's equally distributed. We can all have that absence of that key. Your diet makes it worse. If you got the wrong kind of diet, it actually makes it worse. If you have a better diet, the manifestation is less. And that is why siblings may have the same problem, but one of them's diet is better than the other one, the result of which, the manifestations are milder here or even non-existent, but are very strong in the other side because of diet and lifestyle choices.
Oh, okay. Does it affect fertility?
Very, very much so. Very, very much so.
Menstrual cycle and fertility.
So their major problem is, first of all, the cycle becomes abnormal. So you have longer periods of bleeding when you shouldn't be bleeding. And that's going to affect your sex life because you're not ovulating around that time. And you have periods of no period coming at all. And usually means there's no ovulation. But all these are tied down to the fact that they tend not to ovulate. Now, when you do the scan, the multiple follicles that you see are follicles that have grown, should have gone further to burst and go. But they don't go. They don't burst and go. They grow. Then when they reach like 14 years, let's say, as it's a human being, then they stop growing at 14.
So they stay on the ovary for...
Yeah, they should burst and go. So it's like your elder sister is not getting married, so you can't get married.
So this one blocks.
So the next one too comes, also stops at 14. The next one comes to stop 14. So you have plenty of 14-year-olds in the house, no adults. And the one that should live for the next to grow and follow will not live. Then the rest all cannot live. Then they're all lined up there.
Listeners, Dr. Paddy is talking in parables, if you get what he's saying. Yeah, so please get that clear. And join us also live on TikTok and follow us. I'm seeing the numbers. The viewership is increasing. If you are there, you want to say hi, you want to ask the question, please, you are free to do that. Infertility is such a big deal.
Yes.
And so for me, I know there are other factors that could lead to infertility. But in your studies, what are you finding in the relations between PCOS and infertility? So
I'll tell you this. When we were in med school, the teaching was that the major cause of infertility in Africa is blocked tubes.
Okay.
I later on discovered that is not the case.
How many years ago was that?
Oh, yeah.
Okay, please, let's go.
Let's say in 2 years, we'll be celebrating our 30 years.
Wow. That's a
in
long
2 years,
time
it'll be
to have
30
left
years.
medical school. Yeah.
We'll have our 30-year anniversary. We are planning it already. It's going to be nice.
Oh, nice. I would love to be part of that, just to watch how you've become now. I'm sure there'll be old pictures of you in medical school.
One of my classmates he has a video of our graduation, so he intends to show it.
Oh, wow. That would be nice.
It will be horrible.
You see those...
You see us looking very horrible.
Yeah, those whose stomachs have... Okay.
I was very skinny then, you can imagine, and I have a pot belly.
I've been told.
Yeah, you've been told, but you haven't seen it yourself.
I've been told by one of your mates that.
Yes, I was very skinny.
Yeah, they said you were the small one inside, and you were always the one that caused trouble. It's like you've grown into it now. You're causing trouble at the larger scale.
End of the scale. Yeah.
Okay, so the infertility and fertility.
Yeah. So generally, their major problem is they don't ovulate. So the eggs that every month you're supposed to release one egg, their eggs grow. Instead of, we expect them to grow to 18, 20 millimeters and burst, they grow to 12, 14, and then they stop. So they go 12, 14. So you have plenty of 12, 14s, 10, 10s, and no 18s or 20s that should burst.
So they're not busted.
So they don't finish the maturity to burst. They all get arrested at a particular stage. So that since they don't ovulate, they don't release the egg. Now, every cycle, you grow a follicle which contains an egg, and then at the right time, on your mid-cycle, that follicle bursts, what we call ovulation.
Okay.
The egg is released. The tube grabs the egg, and then the sperm meets the tube, the egg inside the tube.
Exactly.
And then the baby that is formed in the tube now travels into the uterus. That is the natural state of things. These guys, the egg never matures to get to the bursting stage. And so when they should, mid-cycle, they should release an egg. There's no egg released. So you have sex at the right time, you don't get pregnant. Next month, the same thing. Next month, the same thing. Then 1 month or maybe 4 months down the line, you then maybe ovulate that cycle. And then if you don't have sex at that time because of something, you've missed that chance. So whilst everybody has got 12 chances in a year to get pregnant, they may have 4 or 3 or 2 or 1. I've got patients that haven't had the menses for a whole year.
Oh, wow. That's why you said the one who had 3 kids had to have a lot of sex.
Yeah, had to have, because you can't...
Or had to be very lucky or very blessed. Like
her timing was, excellent, on
Yeah.
point. For her to consistently have, whenever she wants to have a child, she does have a child, but she doesn't realize the fact that she's got a problem, even though she has only 4 menses in a year.
But that qualifies as a miracle. Okay, yeah. Please. Okay, I'm going to jump another one.
Sure, please.
Is this thing painful? Does it come with any kind of pain?
Some people describe some kind of pain. I typically don't see it in my patients, but some describe some kind of pain that they have deep in the pelvis. It's not something that I've read about it, but it's not something that I'm familiar with.
Okay. All right. So now let's look at the physique, the acne, the hair growth, the weight gain. Other things cause it. So how are you able to look at this and say, this?
Well, it has to be part. That's why it's part of the basket.
Okay.
So we see you come. A patient may come and say, "Doctor, I have acne and it's not going." Now it's interesting. She comes to a gynecologist because she went to see a dermatologist. The dermatologist says, "Your problem, go and see a gynae." So the skin doctor sends you to us and says, and I specialize in PCOS, so send you to me and say, "Oh, sort out this person's problem because we think it's gynecological." So that's a good dermatologist, because otherwise he'll be trying
to give you creams.
He'll be trying to solve it with creams, and it won't stop because the problem is hormonal.
Wow.
So when they send you to the gynecologist, then we examine you and we look for the other things and say, "Oh, does she have polycystic ovaries in addition to the acne and the excess hair?" We say yes, she has polycystic ovaries. Okay, what does the hormone picture look like? And we look to see whether how her hormones are like, usually during her menses. That's the best time to test. And there are certain parameters that we look for and certain ratios that we look for. When we see those things, we are like, okay, indeed, you do have PCOS. In my center, we actually measure your insulin level. We don't just measure your sugar level, we measure your insulin level, because that's a more direct reflection of what exactly is going on in your body. If your sugar levels are normal, it could be because your insulin is overworking. So it's like children in school, and they are keeping quiet because somebody is shouting at them to keep quiet, not because they are well behaved.
Okay.
You understand? The day that person's voice becomes hoarse and can't shout anymore, that is when you see their true character.
That's a fantastic analogy.
Yeah.
So the insulin now is the one whipping the blood sugar in line.
Yeah.
But the day insulin gets tired, the blood sugar will just...
Yes. So patients come to you and they tell you, "But my sugar is normal." I'm like, "Yeah, but that's not the problem. It's not your sugar. Something is controlling. Something else is controlling." And we check that one, and we've got people who have got very high insulin levels, extremely high insulin levels, very, very high, and you're like shocked, like, hey. So person's walking about with normal sugar is based only because their insulin is really high, to try and keep them under control.
Interesting. In your experience dealing with PCOS, being one of Ghana's foremost in this space, mental health and emotional well-being, does that come with it?
Yes. For some people, tend not to come and tell you that I'm feeling depressed, for you to discover that it is. But in actual fact, you may actually discover she in your investigation of other things, you may discover that she's having emotional problems, and those emotional problems are related to this condition. You must be aware of. So the chemical, that's the key. Okay, so there are 2 types of keys.
Okay.
The key, one of them works directly on sugar and the other one works more on fertility hormones. But the one that works more on the fertility hormones actually works on mood as well. So if your body is not producing that key, you come to us because you've noticed that the periods are misbehaving. But that same key affects your mood. And if you're not producing that key, your mood too goes down. So I've got patients who actually came to me with, and this is where it gets interesting. I've got patients who came to me with mental illness.
Okay.
Somebody came with some kind of depression, and actually came that day because she wasn't my patient. She came with somebody else.
Okay.
So when we talked to that person, and she was in the room just quiet listening, then when she finished, said, "Hey, baby, too, I have." Then she started talking about her periods. Then she talked about her periods. Then we spoke about the relatives now mentioned the fact that she has been treated for this and she's being given medication for that. And so we listened to everything. I was like, okay, you know something? I'm going to address your period, but let's just know that this would also affect your mood and you may discover that it is getting better. So we gave her the medication to correct the period, and then her mood's elevated.
Oh, wow.
So now she's off her antidepressant medications.
Exactly.
And she regularly takes the other one to correct the PCOS. And she doesn't take the antidepressants anymore. Oh, there's another medicine that we've had to give to people who are... This woman comes to see me and she says, hey, she has this problem. She also has bad PCOS. And then she was actually getting electroconvulsive therapy, which is like they actually shock your brain for bad mental illness. We use it for the pretty severe ones because of suicidal thoughts and things of that sort. And we're like, okay, well, we've got something that does this, so we'll give you the 2. We actually gave her 2. And, hopefully to help. Stopped. Didn't need it anymore.
So in that sense, they were tackling the symptoms.
Yeah, not the cause.
Not the cause.
And that is the problem with PCOS. For years, we have tackled the symptoms.
Now we're finding out the cause,
yes.
the culprit.
Yes. That's why I say my theory works.
It's 9:30. If you're joining us, Dr. Paddy is in the studios with us this morning on Health and Wellness Tuesday. We're having a conversation around polycystic ovarian syndrome. He's from Resolve.
Nope.
What was
I
the
used
name?
to work. Elimas Health.
Elimas Health.
Yes.
Oh, that's nice. Where is it?
We have an office practice in the airport residential area, and we are just about opening our wards on the Spintex Road, Committee 18.
Okay. We'll get there. I mean, but
you should come for a visit. You'd like it.
I should?
Yeah, for a visit.
With my wife or myself?
No, just you. Just come for a visit. We're not consulting. Just, come by.
You test me or something?
If you want to. We can test you for the PCOS thing. Just one test. We'll know.
You never know.
If it's misbehaving like, Master, when I'm cancelled, we have to fix it. We'll change your diet one time.
I should.
Yeah, you should.
Mr. Alex Mensah, Mr. Kweku Yankson. When I'm coming, I'll come with the 2 of them.
Yes.
Kweku Yankson especially.
If you look at him and his
way,
body shape.
I know.
They say apple shape. He looks appley.
Yeah, Kweku Yankson.
Not pear, but appley.
No, he looks apple. We should bring Kweku Yankson.
Yes, we should.
So treatment. Is it treatable in the first place?
Very.
So that what? I mean, it's gone.
No, it doesn't go. It's for life. The problem is for life.
Oh, that's scary.
No, it's like look, like an albino. I can't change your albinism.
Okay.
But it's a genetic defect.
Exactly.
It's like sickle cell. Okay, now
you have said that it is genetic.
Okay. So you understand?
Yeah.
Sickle cell, we are doing some things now where we are trying to do some changes in your DNA a little bit to change things. But we can't change that one. But what we can do, so the focus over the years has been manage the symptoms. So your periods are abnormal, you give it a pill.
Okay.
So every time when a client comes and says, I can do anything I want, you tell me what you want. Because if you tell me what success is for you, I will do it for you. But everything depends on what you want, not what I want.
But that's like customer service 101.
Yeah,
but we don't do that. You're the doctor. You should tell her what she needs to know.
Well, in this particular case, it's based on what your objective is. Somebody comes
to give birth.
Yes. So if your objective is to give birth, I shouldn't put you on the pill. If I put you on the pill, you get regular menses. That's not what you want.
You want to give birth.
You want to give birth.
So the person.
If your problem is the excess, the acne,
Mm-hmm.
that is your acne. That's your problem. And I give you ovulation medicines. I haven't solved your problem. What do you want? What is success for you?
Amazing.
The easier ones to fix, I can fix the acne. The excess hair, I can fix it. Getting pregnant, it depends on more than just me.
Yeah, you and somebody else.
You and somebody else.
And the timing.
Yes. So it's a lot more difficult.
Oh, wow.
But there's one other part I haven't even mentioned, maybe I've neglected to mention. They tend to, even after they get pregnant, they lose pregnancies within the first 5 months. A lot.
Oh, miscarrying.
And that has been difficult to solve. It has been the most difficult aspect to solve. It's taken us a long time to figure out what is this thing. A lot of pregnancies have been lost because you keep doing things, it doesn't work.
That's worrying.
So we are about getting to the stage where we figured out what we can do for them to ensure they keep their pregnancies. But it's been a long, painful journey. In my whole life with PCOS, that has been the most painful part. But you struggle to get the client pregnant, then they lose their pregnancy. Okay. And you can do all kinds of things for them. But it appears that there are 3 things you have to do to get it to work. And if you're able to get them to agree to do those 3, you will succeed.
Then you're lucky.
But it is tough. I've had, different kinds of patients that have suffered this at various stages. And sometimes you get pushback from the patients. When you tell them you need to do this, and they'll tell you, no, don't do it.
Why?
And then they lose the pregnancy. I've had even insults from people. And I told some guy, this is what we need to do for your wife. And it's urgent. Let's do this, and do this best to save the child because blah, 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 blah. So give you a note. Go to this place, let them do it. They go there and they tell them, oh, let's wait. The guy comes back and says, I don't know my job.
Because somebody said he should wait.
Because someone said he should wait. And I'm like, boom, the outcome will be bad. And the outcome became bad. Years later, he comes back again with his wife that I should help. And I was like, Charlie, that chance was our best chance. Because you had gone furthest. And we had the best chance to keep that baby. You understand? But it happened.
Oh, wow.
So that the losing pregnancy after they get pregnant is the most challenging part. And I think we are at the cusp of consistently being able to manage it. But it comes at a significant cost to the family to get it done. But it can be done.
Financial?
Yes. Not only financial. Wow. But it's that is where the challenge is now. The other parts is pretty well figured out how to manage it.
What are the treatment options? Medication?
Medications. Generally, we use medications. In the olden days, we used to do a procedure we call ovarian drilling, which still works, where I shouldn't use that word. We take off some of the eggs, is the nice way to put it. And the ovary responds by, behaving itself. Let's put it that way.
Okay. Now,
the challenge with that method is that you haven't solved the cause. You've solved the ovarian manifestation of the cause. And the people I've got a friend of mine who actually had the drilling done, and afterwards has had 2 children. I've had patients that I've done drilling for, who they get pregnant 1, 2, they don't even tell you they've gotten pregnant a second time. Next thing, oh, Dr. Mawu, what happened? So my second one, wow. So it works. It works. I've got a couple of stuff even from this country that we've done.
And a medical term uses drilling?
Ovarian drilling, yeah.
That sounds like mining. I mean, it sounds painful.
We need under anesthesia. You are asleep. Laparoscopically, you put a camera through your belly button, put the instrument to the other side, find the ovary, support it, and you drill through some of the things on either side. And the ovary responds by ovulating properly. So it results in you ovulating. That's the good part about it. The bad part about it is that the cause is still not tackled. And so the hormonal causes are still there and they continue. So that is, but that was how we were doing things before. We can put you on the pill, which helps regulate your cycle, and though your menses would come, fairly regularly. However, once again, it doesn't solve, of course, but it doesn't allow you to get pregnant. There are lifestyle changes we can encourage you.
Okay, I was going to come to lifestyle.
To do, yes, and there are lifestyle changes that we have to do that you have to be consistent on, and that too improves your situation and it gets better. And then we can also say, this is the cause. We are going for the cause. And once we go for the course, give yourself a few months, you see that everything starts falling into place. And for some people, that's all you need to do. And I like the course part because it means your benefit is lifelong.
Okay, exactly, because you've
handled the course. The challenge, however, is that patients don't understand that this is a lifelong condition. So yesterday, I see my client. I haven't seen her for a year. And she's like, okay, so you gave me the medication and my menses became regular. And for 6 months, my menses was regular. And so I didn't come because I thought I was healed. And I'm like, oh, sweetie, I told you. Didn't I tell you it's lifelong? He said, you told me. Didn't I tell you that you need to continue taking the medication for life? You told me. Didn't I tell you that because of you are not producing a particular key, we need to keep giving you the key? You told me. So why did you think it's okay to stop your medication for a year? Well, she come back, menses is misbehaving again.
Here we go. Now we come back to square one.
So you have to start all over again.
Okay.
They and the men who have sperm problems, they are the ones who give me the most headaches. Because they start their medication, then they stop. They don't. And I'm like, I explained. Did I not explain to you? Yes, you did. Did I not tell you? Told me everything. Why did you not do it? Oh, I thought. I was thinking it was gone.
I mean, you can't blame us for thinking and being hopeful. You never know, guy. Miracles still happen.
She said she was waiting for healing. So
miracles.
Nothing hasn't come. I'm like, but we've told you what you need. Just do it. You'll be fine.
Diet and nutrition, can they help in managing PCOS?
Yes. If you are
when you say diet, and
okay,
what are we supposed to eat?
So this is what, when we run the tests, we know what type of problem you have.
Okay.
And what those who benefit from diet. Not everybody benefits from diet.
Okay.
But from those who benefit from diet, we give you a particular kind of diet. And we warn you, you can't eat this, you can't eat this. If you eat this, you have to eat like this. And we give you all the instructions. It's quite elaborate. They struggle. But eventually, they get it. I should have brought something today. There's what I have discovered, especially for those whose sugars are abnormal, is that if they have a continuous glucose monitor, they behave. Okay. So we need to start encouraging that, especially for those who are diabetic already. There's a particular monitor that nobody has made yet. The day they make it, I'll be very happy because that will solve our problem. Because then you can change your diet immediately. Because if your sugar becomes abnormal, it's because you have overcome the barrier.
Okay.
I want to be able to detect it before you overcome the barrier. I want to detect it when your body is compensating, but it is not, but you are not, it's not manifesting. So that I can deal with it before your ability to compensate fails.
Explain that again.
Okay, so let me see. If I check your sugar level, your sugar level comes back as normal. It's normal because you are not producing excess sugar, or it is normal because your insulin is overworking. It's overworking,
not working over.
Yeah. The only time your sugar becomes abnormal is when the insulin fails.
Okay.
That for me is too late.
Okay.
Because you're diabetic then.
Then it's too late.
Yes.
But that means that then your work becomes a lot more difficult.
Yes.
Okay.
So we should be able to prevent diabetes rather than waiting till you are diabetic.
Okay.
That is my dream.
Someone has sent a question I need. Does vitamin D play a role in PCOS?
It plays a significant role. And so we've discovered that for most of our people, our vitamin D levels are low. Generally, the black skin makes it difficult to produce vitamin D.
That's why I ask if a certain group of people are prone.
No, the PCOS there is there. But the black skin generally, you see, and
okay.
When we check our vitamin D levels, especially for generally, when we check our vitamin D levels across the board, is low.
Okay.
It's low because we don't spend enough time in the sun. We have a lot of sunshine, but we don't spend enough time in the sun.
We don't walk around in the sun?
Massa, what time do you get here?
5 something.
Excellent. What time do you leave here?
Right after the show.
Okay. So from there, where do you go?
Straight to my office.
Okay. And then you come out from the office at what time?
In the evening.
Around after what?
7.
Okay. Does the sun see you? When was the last time you greeted the sun? And he also said hello back.
Like Saturday morning.
Okay. So your vitamin D is low.
Okay.
You can have all the nutritional consumption of the fatty oils and the rest, but we need sunlight on your skin to convert it into the vitamin D that we use.
So once a week, go walk around in the sun.
If you're not exposed to the sun, you don't get it. So in the Northern European countries, they actually supplement them vitamin D, especially in the winter months, because they know that there's no sun at all.
9 months and all that of darkness.
We have the sun, but we do our best to stay out of it. Now, here's the thing about vitamin D. Vitamin D protects you against disease, inflammation, infections. You understand? And that is why the madman who walks on the streets morning to evening, you don't see him sick.
He even drinks.
And he's drinking gutter water.
Yeah.
You understand? That is why some time ago, when there was a problem in this country, and this is what becomes controversial, those who suffered most were those who work morning to night. And those who were in the streets selling, they say,
why? You're talking about COVID. Why are you not mentioning COVID?
I'm talking about COVID. And that was part of the reason I believe that is why Africa didn't suffer like the way they expected us to suffer.
Yeah, they thought we were all going to fall down.
No,
dead,
yes. Yeah. And that is why when they say I have it, but me, I don't see it. When you ask what they do, market women. How many market women got admitted? It was the bankers, the office workers, the big men. They were suffering the illness. And the man in the streets was protected.
Because of vitamin D. What are you saying?
Yes. I'm just telling you the importance of vitamin D in our life.
What are you suggesting?
Me, I take it too. I'm telling you, I take. I take. Fauci takes. We all take. If I don't take.
Yeah, Fauci.
But we should. What I'm suggesting is that we should expose our body. In addition to a good, we should do some outdoor exercise that allows us to get in the sunlight. And the best exercise is to walk.
It's 9:45. Dr. Paddy Ayeta is here.
We have closed.
we have 10 minutes more to go. He's from Elimas Health Airport, Accra. Obstetrician, gynecologist, female fertility expert. One of the very best we have in the country on PCOS. You can send your questions and your comments. We will have to continue this because the questions are a bit long here. With 10 minutes, we just can't handle all of them. When we come back next week, we'll continue from the fertility and pregnancy angle. Because
we can continue from the questions. And then when we have time, we'll finish.
So let's come back to the issue of pregnancy. Man and woman at home, man is saying to you that do you have those challenges where the two of them are blaming each other, and because of that 7 years in marriage, they still don't, because the man thinks you are the problem, I'm the problem.
We tend not to have them blaming each other. Usually it's the man and his family blaming the woman.
That's a nicer way of putting it.
The women tend not to be blaming the husband. Women are actually very protective of the husbands. Men who come with no sperm at all, the wife is very protective. If even had a case where I know a couple that the man had no sperm, the woman was okay, and the man's mother will come to the house and be insulting the woman, and the husband will say nothing.
Oh, damn.
That for me was painful.
That's terrible.
Yeah, because
all he needed to do is tell mommy I'm the problem.
Yes, and he didn't. And the woman got all the blasting and that kind of stuff, and she wasn't responding because she was protecting her husband. I think women get unfairly blamed for fertility challenges. When we check the percentages, women are responsible for the problem half the time.
Oh, so that 50%
men are responsible for the problem half the time. And there are a lot of men who have low sperm counts, and that you have to give them treatments. Unfortunately, there are too many treatments that don't work, but there are treatments that work. But because we don't have people who specialize in it too well, a lot of people are not getting the right kind of treatment for male infertility. The other thing we need to understand about male infertility is that it takes a longer time to treat. I can make a woman ovulate in 2 months, even if I want in 1 month. I can take control of her cycle totally. But with men, it takes 75 days to produce new sperm. So any medicine I give you, you need to have 75 days of taking it before the sperm will be fully impacted by that medication. In other words, from the time the sperm was conceived out till it was delivered, I need 75 days of that treatment. That also means that if any time the man takes a break, you see I said men give us problem. You use the medication. If he stops 1 month, we are going back to zero.
Start another 75-day cycle.
And typically, it takes 6 months for the sperm to improve. So I've had clients who have come to see me, and I'm like, this is the problem, this is the medication you have to take. And they've been consistent. Unfortunately, they are not in the majority. They've taken their medication consistently, religiously. Every time they'll come, they'll take it. There are some that you can't travel with. So you have to get you a different type just because they are traveling. I'm traveling, so I need the other type. When they come back, I'll take this one. And they've taken it consistently. And then you do a procedure for them, an IVF or something. They produce the sperm, and biologists say, I'm very happy with the sperm. And this is somebody who came with very poor sperm. And after 6 months of treatment, sperm is good. He gets a good outcome. There's another one. The wife had PCOS, but he came with a sperm problem. We gave him the medication for the sperm, gave the wife medication for PCOS, and he took the medication consistent. After 6 months, she got pregnant.
Oh, wow.
Of consistent taking, she got pregnant. Then they had a baby.
Oh, wow.
Then the guy calls me and says, hey, boss, we want to have a second one, so I want to come and resume my medication.
Amazing.
He called me himself. The next week, he called me, hey, Charlie, she's pregnant again. Oh.
Wow.
We didn't even resume. That tells you that his consistency was rewarded.
Yeah.
But it must be the right medication. Most unfortunately, we have got all kinds of things that don't work when it comes to, especially when it comes to sperm. But some work.
When you say all kinds of things,
there are kinds of medications that we give that don't work.
Western medicine or local medicine?
Both. That don't work. Even Western medication, there are some things. There's some medication that you've given, from when I was in Kulebu, we've given, it doesn't make a difference. Now there are medications that we are using now that actually makes a difference. And so it's getting the right kind of medication and taking it for the right duration. There's a new thing we are working on that we are trying to actually rejuvenate the testes and the ovaries. So we are trying to see how that would work. So older people, you fire them the thing and then give them 2 months and see if they'll produce more eggs or more
just
sperm.
for scientific finding.
Well, some people have done it. Some people have done it. No, people want to give birth. And some people have done it successfully and they've gotten some results out of it at the 30% are getting. So if from 0 you're moving 30%.
Rich people who want hairs to their properties.
No, some of them are pretty
average
Ghanaians and they're like, Charlie, I've been told that there's no hope for me. Then you'd give them options, option A, B, C. Then they say, no, I want this one. I'm like, yeah, but it's not 100%. It's only 30% of our result. It's like, yeah, but right now I'm at 0. So 30% for me means 1 in 3.
Exactly.
I'll take those odds.
I'll take that odds.
I'll take those odds.
You're working miracles. What fertility treatments are available for women in PCOS? Let's go back to
that. There are many treatments that we can give. For fertility in particular, the objective is we need to get you to ovulate. So we focus on fix the background problems. And then when you fix the background problems, she would naturally ovulate. If she doesn't naturally ovulate, you need to stimulate her a little bit. And we can give you various kinds of stimulation. Tablets and injections, fully injections, all the way to IVF. And then if we do those things, we'll get the eggs that we need. And then if we give you medications and you start ovulating, your chances are now like a normal person, which is 20%.
Okay.
Which is 20%. So that means you have a 1 in 5 chance of getting pregnant, like a normal person. That means over 6 months, consistently, you should be able to get pregnant.
What are you saying? A normal person has just 1 in 5?
20%, yeah. So 10 people have sex at the right time. They ovulate.
Uh-huh.
Only 2 will get pregnant.
How is teenage pregnancy so high with this low rate?
Because at that time, your chances are far higher than somebody who is 35.
Perfect sense.
So a teenager can have sex once, she'll get pregnant.
She's in trouble.
Yeah.
Oh, wow.
A 30-year-old woman can have sex 5 times maybe before she'll get pregnant. A 40-year-old woman, she can do the whole year. Maybe nothing happen.
I get it. Yeah. I mean, it's ringing in my mind. So.
And take note, usually the teenage pregnancy girl is also having sex with somebody who's also fairly young.
And so what? There's more virility
Yes,
there?
because for men, after 45, sperm quality declines significantly. For women, after 35, it declines significantly. So women, please, have your children before 35.
I mean, you're saying they shouldn't put off childbirth for job and
never. It's not worth it. It's not worth it.
Oh, wow.
It's not worth it. We'll can have a discussion in detail about life.
I would love to have a discussion with you.
I sit at the end where we talk a lot about life, the choices that people have made, and the decisions they are trying to make now to compensate for the choices they made earlier.
Because I'm thinking the normal one, especially for someone like me, I did close to a decade in banking.
Mm-hmm.
You got a job, you want to rise through the ranks, childbirth, let's hold on a little. You're saying it is not worth it.
Rise through the ranks for what?
MD.
So that what will happen?
of the bank.
When you understand life and its fulfillment, then you can understand that MD can be there very miserable. And cleaner. Have you seen a Ghanaian woman who serves food in UK who sings every day to her clients?
Yeah.
There's a video of it. Look for it. Happy woman. She's an oddly. She serves food. Delighted with her life. Very fulfilled. Her joy was so much that BBC actually covered her. All the work you've done, has BBC come to mind you?
No. Oh, wow.
You see, we need to figure life out and then decide as to what really brings joy and then focus on that. Because sometimes we are sold the wrong story. And women work too hard.
I didn't expect this conversation to go into that direction.
Well, you got it there. You took it there.
I was just going to wrap up on fertility. Next week, we go into some other areas.
So we'll do a live discussion one day.
We should do live. Yeah. One of these Mondays, personal development Mondays, we should do live because you are sitting at a place where when people come to you, 99% of the time they have a problem. Mm-hmm. So you would appreciate life.
And they are evaluating their choices. And they are telling you, I regret this decision. I shouldn't have done things like this or like that or like that.
Mr. Producer, I need to bring Dr. Paddy back for one of the Monday discussions.
So we need to let young people know because they are in a position to make the right kind of choices. Unfortunately, nobody sat us down to teach us life when we're young.
No, nobody teaches life. You live it.
Yes. But if you had guidance,
you do far better.
Your choices would be far better.
On this very poignant note, it's 5 minutes to 10. We have to wrap up. Doc has to go back to work. Dr. Paddy Ayete is the Chief Executive Officer, Medical Director, Senior Specialist, Gynecologist, the PCOS. I read this. He doesn't want me to read. Ghana's foremost authority on PCOS. If I would say that, if I say, but you already get it. We are saying things that what's the name? The Lancet and the rest will come looking for us right here. He's from Elimas Health Airport, Accra, Ghana, and this is part one. And I see a lot of people logging on the TikTok and all that. This is just part one. We'll continue next week on health and wellness right here on Z in the Morning. Thank you so much, Doc, for coming through. It's always a pleasure to